Good afternoon, everyone. Thank you for staying with us past the buffet. Just to mention that that's my previous role. I now work in HIV surveillance. So today I have the opportunity to talk about telemedicine. And as we've heard, we do have a shortage of specialists in our country. So telemedicine refers to the provision of remote healthcare services through the use of digital tools. The World Health Organization has a more contorted definition of that, where they do refer to the critical aspect of distance and the provision of health skills. Telemedicine holds significant opportunities addressing challenges such as limited access to healthcare workforce shortages, and infrastructure constraints. The COVID-19 pandemic epitomized the increasing importance of digital health technologies across the globe. So beyond video conferencing, which most of us may be familiar with, you can actually do remote monitoring. I'll show a few studies on that, using wearable devices for people in remote places to transmit their clinical data. You can also use secure messaging and teleconsultation, which we do in the long COVID clinic here in Zambia. You can also do e-prescriptions. In fact, telemedicine is not new. Since the early 20th century, Dr. Hugo Gernsback, who's essentially considered the father of sci-fi, really thought about remotely examining patients using robotic arms. And the Nebraska Psychiatric Institute was able to provide medical care for the first time to a patient that was more than 80 km away. By 1960, NASA was actually providing telehealth care to its astronauts. And in the 1990s, we had transformation of telemedicine by the internet. And this led to us being able to monitor patients remotely. And this means they are home, you're able to get their blood pressure, their oxygen saturations. And in the 2000s, we were able to have video chat programs, and now, 2020, telemedicine is actually projected to be a key part of modern healthcare delivery. For countries that were fortunate enough to have telemedicine, in this report, you can see in the US, the use of telemedicine went up 40-fold from the pre-COVID baseline. And in this study that was done by Anna and colleagues, they were able to do telemonitoring in long COVID patients, and they actually detected 3 critical events and responded to that to patients in their homes, and these are long COVID patients. I like this paper from Poland that looked not only at the strengths and opportunities for telemedicine, but also the threats, such as the contacts between the doctor and the patient. So in our culture, we are used to in-physical consultation. So what does this mean for us to transition to this type of care? And also the weaknesses. Essentially, the initial investments are quite high, and you need a lot of time. Over time, these offset themselves. In this pilot telemonitoring program, they actually were able to predict the trajectory of patients in their homes and their clinical course. And what was very important here is that if you have an oxygen saturation of less than 94% in your home, it's likely that your recovery will be slow. And they noted that these patients also had increased variability in their day-to-day oxygen saturation. Of course, this is an area that still requires investigation. So where we are as a country, unfortunately, the penetration for telemedicine in Zambia remains very low. There is some support from the Indian government, and the UTH is linked to some hubs in India. At the moment, we have no in-country national telemedicine network. The Ministry of Health, through the Zambia National Public Health Institute, is working to establish telemedicine services across the country, and the super hub will actually be at the Institute of Digital Health. So this will be used to reinforce care for maternal, to reduce maternal mortality, reduce adverse outcomes in newborns and neonates, and also improve overall health outcomes for people with non-communicable diseases. And also, we are looking at the surgical piece, because the e-health lead is a surgeon, to actually look at patients who are presenting late to specialist care. All these were negatively impacted by the COVID-19 pandemic. So telemedicine services will focus on fostering networks and peer support for the healthcare workforce, from those in the lower facility to those in the tertiary and quaternary facilities. One exciting part is we'll have telesurgery, and you'll be able to have real-time remote participation, particularly for those in training. You can imagine the reduced overcrowding in operating theaters, which is not good for infection prevention. So telemedicine essentially uses a hub and spoke model, and as I mentioned, there will be a super hub, which will be at the Institute of Digital Health. So far, these are the 5 provinces that are earmarked for the rollout, and the start-off will be 4 facilities per province. I wanted to share with you the work by Morehouse School of Medicine. We work with them at UTH. They provided us with the first proof of concept of how telemedicine can work in Zambia. However, they have moved on to actually full implementation. They conceptualized this in collaboration with the Ministry of Health at the height of the COVID-19 pandemic, with the overall aim to reduce and improve outcomes for patients on ART. So you can see so far they've set up 5 hub sites, and one of them is at UTH. We are very privileged because we are actually leveraging on this one for our long COVID, and they have more than 10 spoke sites in the peripheral clinics. We have seen benefit for the HIV program, for instance, when it comes to improved management of patients with high viral load, and also in terms of reduced wait time, in terms of appointment for our patients. Just a quick look at their data, because monitoring is important. You can see that of those that are eligible, they define eligibility as those within a certain perimeter of the spoke site. You can see that their retention actually stands at less than 5%. Our national target is actually 10%, which shows you the capacity of this program to improve retention, because retention is one of the areas that the HIV program is struggling with. So the services they have incorporated in here include mental health, which is critical in COVID-19 and long COVID. It's a pity we don't have a session on that. And also they've included pre- and post-surgical reviews. They also are able to look at abnormal vital signs, and they do help with advanced HIV disease. So far, this program will actually be expanding within the Lusaka sub-district and geographically across Zambia. So this is the long COVID team. Most of them are here. Please take time to speak to them. Actually, Zambia is one of the few African countries that has a well-functioning, well-oiled long COVID service. We have 13 long COVID service clinics, and we are already doing some telemedicine there through telephonic reviews. We are in the process of exploring post-acute COVID-19 virtual care. So the opportunities for telemedicine for countries such as ours are many. I will point out things like emergency response and disaster management, capacity building and training, and of course, eventually you can reduce healthcare costs. In conclusion, what does success look like in telemedicine? We need to ensure that telemedicine solutions are culturally sensitive and inclusive, bearing in mind our infrastructure limitations, the regulatory frameworks, and data privacy concerns. I should have put that one in red. It's a big one. Collaborative efforts involving governments, healthcare providers, tech developers, and importantly, the communities are crucial for successful implementation. We need to evaluate the impact. What is quality of care delivered in telemedicine as opposed to in-person care? And how is the access, and of course, the cost? I will stop here, but not without acknowledging these key players in the telemedicine field in Zambia, because this is the future. And these are the references. Thank you.